At the outset, I thank ISA Kerala and Dr. Vijesh, Dr. Rajesh for having given me this opportunity to talk in the PG update on interpretation of arterial blood gases. Whenever the interpretation of arterial blood gases is occurring in examination, usually the candidates are afraid and they are upset. So the females will express it outside and the boys will hide it inside, but they are upset actually. So my idea is to present the interpretation of arterial blood gases. That too, they have given me rapid interpretation of arterial blood gases, especially for examination point of view. So I will not give much of a detail in this lecture, just an interpretation to make up in the examination. So even if you are could not able to understand the minor points, you don't bother. If you could interpret the arterial blood gases, at the end of my lecture, I will give some quiz for you. And if you interpret it, you can be confident of interpretation of arterial blood gases. So I will give some introduction. Straight away, I will go to interpretation of arterial blood gases so that it will be rapid interpretation. So first warm up. So these are all the things you know. Normal blood pH 7.36 to 7.44. If it is less, it is acidosis. If it is more, it is alkalosis. So how it is maintained with the normal range? That's my lecture. I will give a clue. So you should know there are some strong ions. What are strong ions? The strong ions dissociates completely. So the extracellular strong ions are sodium and chloride. The other strong ions are potassium, sulfate, magnesium, and calcium. Why we call it as strong ions? This strong ion difference makes some calculations in the interpretation of ABG. So it is sum of the total charges by strong cations like sodium, potassium, magnesium, calcium, minus chloride by other anions. It is 40 to 44. So why we call it as strong ions? The strong ions, they are an independent variable. Whereas the hydrogen ion concentration and hydroxy OH ions are dependent variables. Any change in SID will affect the hydrogen ion or hydroxyl ion concentration, but these SIDs will change independently. Then comes the anion gap. Routinely it is asked as a short notes in examination. So this is the difference between the strong cations minus anions, that is sodium plus potassium minus chloride plus bicarbonate. Normally it is 14 to 18. So if more than 20, it is acidosis by unmeasured anions. So that is the reason I have given you the clue here. See, imagine this is the measured cations, this is the measured anions, and this is the unmeasured anions. This is what we call it as anion gap. So if it is not widening, see, if it is not widening, it means only chloride is preserved, because as I said, the HCO3 is not an independent variable. It should vary according to the strong cations. It is not a strong ion. So if it is not widening, somehow the chloride is preserved. So it is minus, and chloride, if it is preserved, there will not be any change. So straight, how to interpret the arterial blood gases? So we all should know that this hydrogen ion concentration, when it is 40 in nanomoles, the pH will be 7.4. So the pH is the power of hydrogen. So I will give a clue for the postgraduates. Simple clue. Usually the hydrogen ion concentration in nanomoles will be 80 minus last 2 digits of pH. This you should remember. See, 40, 80 minus last 2 digits is 7.4. 50, 7.3. 60, it should be 7.2, but it is 7.22. That means a little bit of a difference will not make a big difference in the interpretation of arterial blood gases. This thing you have to remember, because the PCO2 will also be calculated in this simple mathematics, that is mnemonic. So now you remember this mnemonic. The H plus is equal to 80 minus last two digits of pH. Then the Henderson-Hasselbalch equation, you know, Hassel-free equation. I have mentioned it like that. The Henderson-Hasselbalch equation is pH equal to pK plus log bicarb minus dissolved carbon dioxide. This you should know. There is an equation called the Henderson-Hasselbalch equation. We need not go into the detail because then that will be an academic lecture. So you go through that. So the standard bicarbonate. What is the standard bicarbonate? Sometimes it is mentioned like that. The standard bicarbonate, measured bicarbonate is different, but measured bicarbonate changes according to the carbon dioxide concentration, which is affected by the respiration. So the plasma bicarbonate, after equilibration to a PaCO2 of 40 with normal PO2, that is above 100 millimeters of mercury at a normal temperature 37. So this standard bicarbonate and the measured bicarbonate difference reflects respiratory influence on metabolic component. You should remember the bicarbonate changes according to the carbon dioxide concentration, because carbon dioxide with water, it forms carbonic acid, which dissociates into H plus and HCO3. The H plus is buffered by the non-bicarbonate buffers like sulfate, proteins, hemoglobin. So the bicarbonate is left out, but H plus is buffered. So the standard bicarbonate reflects the respiratory influence on metabolic component. Then comes the base excess. So the base excess is the amount of strong acid that must be added to each liter of fully oxygenated blood to return the pH to 7.4 at a temperature of 37 and a PCO2 of 40. This will also be asked as a short notes, the base excess. So the normal base excess value will be -2 to +2 milliequivalent per liter. And to add to the confusion, instead of saying base deficit, as we have mentioned it as base excess, the base deficit is marked as negative base excess. Negative base excess means there is a base deficit. It happens in metabolic acidosis. Then to add to your confusion further, there will be a standard base excess, SPE. Base excess is the amount of base excess in the blood. This standard base excess is the base excess in ECF. Don't bother about it because it will not influence your interpretation of arterial blood gases clinically. So the oxygenation indices, you have to know, the oxygen content of the blood is hemoglobin multiplied by oxygen saturation plus dissolved oxygen. So you have to remember this hemoglobin is a main content in this indices, and multiplied by cardiac output, it is a total delivery of oxygen. So the oxygen saturation is not a measured value. It is only derived from the oxygen dissociation curve, you should note. So the alveolar arterial oxygen gradient is important because you have to differentiate between the respiratory failure due to ventilation failure as well as due to oxygen failure. To differentiate that, you need the alveolar arterial oxygen concentration. So what is that alveolar arterial oxygen difference? Usually, the inspired oxygen is 21% in the atmospheric air. So in the inspired oxygen concentration is 760 is the atmospheric pressure, -45 is the saturated vapor pressure, is the energy spent on the humidification of inspired gases. So it has to be deducted. So this is 715 multiplied by FiO2, that is 0.21 for 21%. It is 0.21. So the inspired oxygen concentration is 150. You should know in the oxygen cascade. It is very simple. So the oxygen enters, the inspired oxygen pressure is 150. The 150 enters, but this 150, once it reaches the alveoli, the partial pressure is becoming 100. Why it is becoming 100? It is the alveolar oxygen partial pressure. This alveolar oxygen partial pressure is the inspiratory oxygen partial pressure minus carbon dioxide partial pressure divided by the respiratory quotient. This respiratory quotient is a constant. So it is 150, normal PCO2 is 40, divided by 0.8 is 50. So 150 minus 100, 50 is 100. This 100 is the alveolar oxygen partial pressure. So here it is 150, here it becomes 100. What happens once it reaches the capillary? What happens? It is only 90. So here it is 100. It reaches this, when it reaches the capillary blood, it becomes 90. So 85 to 100 will be the normal PaO2. So the alveolar oxygen partial pressure minus the arterial oxygen partial pressure is the 10 millimeter of mercury will be normal. This is alveolar arterial oxygen difference. So this alveolar arterial oxygen difference, I will explain why it is important. It is used to differentiate between the oxygenation failure and ventilation failure. See, now imagine if the PCO2 is 40, you know PaO2 is 150. So it is 100. So it is normal. Alveolar PaO2 is 100. But here the PaO2, if the PaO2 is 45 in the capillaries, it means the difference will be 55. So what happens? Here it is 100. Here it is 45. That means there is a block here. There is a block here, that is oxygenation failure. So if the interspace is thickened due to pulmonary edema or the interstitial lung disease, then there will be oxygenation failure. So whatever comes here, it is not reaching properly the capillaries. This is oxygenation failure because there is a wide gap. Imagine the same 150, if the PCO2 is 80, you know, this is respiratory acidosis. So when the patient is not able to breathe properly, when there is a ventilation failure, carbon dioxide accumulates. But here what happens? The alveolar O2 is 100. It is right, it is 100. But the same PaO2, if it is 45 means here, just because the PCO2 is 80 divided by 0.8, 150 minus 100, here it comes as 50. So the alveolar partial pressure is 50. 50 minus the PaO2 of 45 is 5. So here the difference is normal. The alveolar arterial oxygen difference is normal, but PCO2 is elevated. So it is ventilation failure. Here there is a wide gap. It is oxygenation failure. Here it means there is no problem here in ventilation failure. Whatever is reaching here, it reaches less. So it is called ventilation failure. So here the PCO2 is 80 and the normal PaO2, expected PaO2, easy remembrance, it is FiO2 multiplied by 5 equal to PaO2. That is actually the percentage. So normally 21 is the oxygen, inspired oxygen concentration, room air. So for ease remembrance, it is kept as 20 multiplied by 500. So whenever you interpret oxygen ABG, you first check what is the FiO2. Then only you should interpret the PaO2. So you ascertain whether the blood sample is a venous blood gas or arterial blood gas. This is important when there is hypotension and when there is a impalpable pulse. So you there are so many ways of differentiating these venous blood gases and arterial blood gases. So you ensure. So now these are the normal values: pH 7.4, PaCO2 40, PaO2 80 to 100, and bicarb is 22 to 26. That is a normal value. Saturation is should be greater than 95. And as I said, always mention and see this FiO2. So come for warming up is over. Now we are entering the subject proper. There are how to interpret. There are five steps in interpreting arterial blood gases. The first is very easy for you. Check the pH. So if it is acidemic, it is less than 7.3. Alkalosis, it is greater than 7.45. So this is a child's play. This everyone will identify whether it is acidosis or alkalosis. So then you have to go, before going further, you should know who is the culprit. Once it is identified acidosis or alkalosis, who is the culprit? In that you should know pH and the carbon dioxide are changing in the opposite direction. So when the carbon dioxide increases, pH decreases. When carbon dioxide decreases, pH increases. So they are traveling in opposite direction, whereas bicarb and pH, they travel in the same direction. Bicarb, when it is low, pH is low. So just because it is happening, this carbon dioxide and bicarbonate, most of the times as a compensatory mechanism, they travel in opposite direction. Then you have to find out who is responsible for the change in pH. So acidemia, when the bicarb is less than 20, it is metabolic. When PCO2 is greater than 45, opposite direction, it is respiratory. Alkalosis, ulta. When the bicarbonate is more than 28, it is metabolic. PCO2 less than 35, it is respiratory. That step is over. If there is the primary respiratory disturbance, if it is respiratory, then you have to find out whether that respiratory disturbance is acute or chronic. So first two step easy. Now little bit complicated we are entering. If there is a respiratory disturbance like respiratory acidosis or respiratory alkalosis, then you have to find out whether that respiratory problem is acute or chronic. How to make it out? That 10 millimeter change in PaCO2 will produce 0.08 change in pH. That is acute. But if it is chronic, 0.03. That means the disturbance in pH will be less for the same increase in PaCO2 because in chronic, the compensatory mechanisms take place. So this is 0.08, this is 0.03. There is a method to remember that 0.08 and 0.03. I will come back to it later. So the step 4, that is respiratory. Now, if the disturbance is metabolic, then you have to find out whether the respiratory compensation is appropriate and what happens to the anion gap. So if it is respiratory, you check whether it is acute or chronic. If it is metabolic, you check whether there is adequate respiratory compensation and what happens to the anion gap. So in metabolic acidosis, the expected PaCO2 should be 1.5 into bicarb concentration plus 8. So plus or minus 2. Easy remembrance, as I said. Now go back to the first slide. That is pH. The last 2 digits of pH denotes hydrogen ion concentration in nanomole. The expected PaCO2 is easy last 2 digits of pH. But this is the actual calculation. But for rapid interpretation, you can use this. This is my way of interpreting. Last 2 digits of pH will always be helpful. So for metabolic alkalosis, if it is metabolic alkalosis, the expected PaCO2 is 6 millimeter for every 10 milliequivalent rise in bicarbonate. So remember, this is 1.5. This is 6 because this is should be remembered for easy interpretation of arterial blood gases. This is scientific, but the easiest way I will tell. So this you remember. This is the slide which I showed previously. The hydrogen ion concentration is 80 minus last 2 digits of pH. Same way, the last 2 digits of pH will be the carbon dioxide concentration. Now remember, if it is 7.3, that is acidosis, then the carbon dioxide concentration could be 50. That is respiratory acidosis. If it is, so you have to remember that way. If the pH is 7.22, then that means carbon dioxide is elevated more. Here you have to go back to that. See, the expected PaCO2 is last 2 digits of pH. That is the expected PaCO2. So if it is 7.22, that is metabolic acidosis. If it is a 7.22, the expected carbon dioxide will be 22 because it has to be compensated by respiratory alkalosis. So the expected should be the last 2 digits of pH. So if the actual PaCO2 is more than expected, that is when there is a metabolic acidosis, and when the actual PaCO2 is more than expected PaCO2, it means there is additional respiratory acidosis, that is mixed acidosis. But these sort of difficult things will not be given in your oral examination. When you answer very extraordinarily good, then only the mixed parameters will be given. Usually the examiners will be liberal. They will not give all these things. Just a basic, they want to know whether you know the basics of ABG. So when the actual PaCO2 is less than expected, it means additional respiratory alkalosis. Step 4 is continued. If there is metabolic acidosis, as I said, check the anion gap. So if the anion gap is greater than 12, it is a wide anion gap acidosis. So the mnemonic will be mud piles. Mud piles are the comma. This we need not know. Examiners will ask you, you tell me a few causes of increased anion gap acidosis. So at that time we can use. So you have to check anion gap. So fifth step is most important, a clinical correlation, because only by clinical correlation you have to expect what is happening, then only you can interpret. So there are 5 ways. Okay. So as a recap, so the same direction change. So bicarbonate and pH, they travel in the same way. Carbon dioxide and pH travel in the opposite direction. So you have to remember the format. You have to check pH, PaCO2 and PO2. These are all the calculated parameters. Others are derived parameters. So now I will give you the clues. So as I said, the PaCO2 change of 10, if it is an acute change, it will produce a change in pH 0.08. If it is a chronic change, it is 0.03. So you remember 0.08 and see if the 8 is divided exactly, it is halved like this, it will come as 3. So see, you have to cut it like that. If you cut it like that, it comes to 233 and a mirror image of 3. So for acute change, it is 0.8 and for chronic change, it is 0.03. So interpretation of ABG with that, first look for pH, who is the culprit. If it is a respiratory, whether the change is acute or chronic. If metabolic, compensation, anion gap, clinical correlation. So the compensation is considered complete when the pH is returned to normal range. Now, I will give you an easy clue so you remember these statements. Acute respiratory acidosis, for every 10 millimeter rise in carbon dioxide, 1 millimole of carbon dioxide will be increasing. So in acute respiratory alkalosis, we know in respiratory alkalosis, there will be a fall in PaCO2. So for every 10 millimeter of mercury fall in PaCO2, there will be 2 millimole decrease in bicarbonate, because bicarbonate has to decrease because then only it can produce metabolic acidosis. So in chronic respiratory acidosis, for every 10 millimeter rise in PaCO2, 3 millimole increase in bicarbonate will be there. In acute, it will be 1 millimole. In chronic, it will be 3 millimole because the compensatory mechanisms take place in chronic respiratory acidosis. So in chronic respiratory alkalosis, for every 10 mm fall in PaCO2, 4 millimole decrease in bicarb. In acute, it is 2 millimole decrease in bicarb, but here it is 4 millimole decrease in bicarb. So you have to remember 1, 2, 3, 4. So the compensation is 1, 2, 3, 4. For any process, first is acute. So you write first acute respiratory acidosis. Second, you write acute respiratory alkalosis. Third, you write chronic respiratory acidosis. Fourth, you write chronic respiratory alkalosis. Then put 10. 10 is the same everywhere. And once it is acidosis, you know carbon dioxide is increasing. So put 10 millimeter carbon dioxide rise, then this 1 comes. Same way, alkalosis 10 millimeter fall, then 2 comes. Chronic respiratory acidosis, rise in PCO2, 3 comes, 4 comes. So it is 1, 2, 3, 4. Here it is acute, acute, then chronic, chronic. So you can easily remember with this. Then if you want to 5, 6, that is 1, 2, 3, 4. If you want to 5, 6, again, the previous slide you recollect, for metabolic acidosis, for compensation, the expected PaCO2 is 1.5. So 0.5, here comes that 5. Into HCO3 plus 8 plus or minus 2. It is very difficult to remember. So in rapid interpretation, you can take this expected PaCO2 will be last 2 digits of pH. So for metabolic alkalosis, PaCO2 6 millimeter for every 10 milliequivalent rise in bicarb. So this is 6. So 1, 2, 3, 4, 1.5 is 5, then this 6. So you remember that. So if the actual PaCO2 is more than expected, additional respiratory acidosis. The actual PaCO2 is less than expected, additional respiratory alkalosis. Now, if you interpret all these questions, you can be confident of interpretation of ABG, at least for the examination. So this is a quiz time, but don't worry, no marks will be given for this. I will give you the answers, so you don't bother. You just check. I'm giving you the history because, as I said, the 5th point will be clinical correlation. But here it is as in no relevance. This ABG results show pH 7.39. So it is less than 7.4, but somewhere it is within the normal range. So the PaCO2 is 27 and the bicarb is 19. So what does it mean? More or less it is normal, that pH, but PaCO2 is decreased and bicarb is also decreased. So it could be respiratory alkalosis compensated by metabolic acidosis, or metabolic acidosis compensated by respiratory alkalosis. In this case, for easy interpretation, as I have given 4 answers, you have to select. First, it is acidosis, no doubt it is less than 7.4. So as it is on the acidotic side, the primary disturbance will be acidosis. So you have to take this bicarbonate only, that is metabolic acidosis. So it is metabolic acidosis fully compensated. That is the reason why the pH is coming back to normal. It is metabolic acidosis fully compensated. You should not say it is respiratory alkalosis compensated by metabolic acidosis. It is wrong. Same way, a patient has undergone abdominal surgery. The Rayleigh tube aspiration is 900 cc, coffee ground secretions, ABG 7.5. So once this 7.5 comes, it is alkalosis. Then you expect either bicarb should increase or PaCO2 to decrease. But PaCO2 it is 37. So instead of 35 to 45, it is 37 normal. But bicarb is 30, so definitely it is elevated. So it could be metabolic alkalosis uncompensated. So it is metabolic alkalosis uncompensated. Then you remember this. This history, it is I have given just for reference. So this ABG reveal 7.6. So 7.6 means it is alkalosis compulsory. PaCO2 is reduced as we expected. It could be respiratory alkalosis, and bicarb is 25 normal range. So it is respiratory alkalosis not compensated because pH is more. So it is respiratory alkalosis uncompensated. Same way, a 3-year-old boy has some problem. The ABG showed 7.35. So 7.35 means it is on the acidotic side. And PaCO2 is 72. So it is respiratory acidosis. Then the bicarb is 38. So it is also increasing. So the respiratory acidosis with compensatory metabolic alkalosis. So as it is compensating, the pH is nearly normal because 7.36 is normal, but here it is 7.35. But you have to pick up only the answers from here. So instead of 7.36, it is 7.35. Same way, a 54-year-old man with COPD, pH is 7.3. So it is acidosis. PaCO2 68, respiratory acidosis possible because he is having COPD. So bicarb is 28, it is on the higher side of the normal, and PaO2 is 60, there is a hypoxia. So this patient has respiratory acidosis uncompensated because the pH is on the less side, acidotic side. So here the 16-year-old student is having a pH of 7. So the 7 means definitely it is acidosis. PaO2 90, PaCO2 23. So it is not a respiratory acidosis. So here bicarb is 12. That is the reason why there is a respiratory alkalosis. So this could be metabolic acidosis. It is metabolic acidosis. It is not compensated. So metabolic acidosis not compensated because pH is less. Same way, a chronic smoker, pH 7.6, it is on the alkalotic side. PaO2 is 120, PaCO2 is 31, and the bicarb is 25. So what does it mean? The PaCO2 is reduced. So, but pH is 7.6. So what is happening? It is a respiratory alkalosis not compensated because bicarb is not changing, not going for compensation. Here, the pH is 7.5. PO2 is 85, PaCO2 is 40, PaCO2 is normal, bicarbonate is 34. So it is metabolic alkalosis not compensated. I am giving you so many examples so that you can refresh and you can be confident. So you check. Now I have omitted the history so that you can easily concentrate. pH is 7.1, acidotic. PaCO2 is 70, respiratory acidosis. This is normal. So respiratory acidosis not compensated. These are all the simple things. Now we are going to the analytical part. The next step, if you are so sure about interpreting all these things, we are going one step further. So instead of giving a lecture, if I give you the examples, you will be easily understand. So now what is happening? Now interpret this. This is pH 7.52, PaCO2 30. So what is happening here? It is acute respiratory alkalosis because the PaCO2 has come down. Bicarbonate is not compensating. If it is a chronic, it would have compensated. Okay. Now, this is a progressive respiratory distress. That is the reason I am giving you the history. If it is a progressive respiratory distress, there is a chronic illness. So we have to note that. So here the pH is 7.31. pH 7.31 is acidemia. PaCO2 is 76.2. It is respiratory acidosis. Respiratory acidosis. Now, what I want you to interpret. So the expected pH for acute change is 0.08. Because if it is chronic, it should be 0.03. So for 10 millimeter difference in PaCO2, the difference should be 0.08 in pH. So here it is 7.31. So 0.29 is the difference. So the expected pH should be 7.11, but here it is 7.31. So the progressive means there is a chronic respiratory acidosis. Now there is hypoxemia, 45.5. But that AA gradient is given. The AA gradient is 9.5. Up to 10 is normal. So the AA gradient is normal. So what is the problem? Hypoventilation. If it is AA difference is more, it is oxygenation deficit. Now it is a chronic respiratory acidosis. There is hypoxia and it is due to hypoventilation. This hypoxia and hypercarbia are due to hypoventilation. That is the reason the patient is going for progressive respiratory distress, probably some neurological illness. So here, the 8-year-old male asthmatic, 3 days of cough. So 3 days is a good time for compensation, orthopnea. So now, what is happening now? Check. The 7.24 is acidemia. What happens to PaCO2? PaCO2 is increased, so it is respiratory acidosis. Then the expected pH, as it is acute, the difference should be 0.02. So the expected pH is 7.32, but here it is 7.24. So it is more or less, it is near normal. So it could be acute respiratory acidosis, because if it is a chronic respiratory acidosis, the difference should be only 0.03. Then it will work out to 7.1. So it is acute respiratory acidosis. This sort of a compromise we have to make in interpretation. Now, with the increase in carbon dioxide, bicarbonate should rise, but here bicarbonate is decreased, 18. So there is a possibility of metabolic acidosis with respiratory acidosis. And here the 66 is hypoxia, and here the difference, you have to check the difference. See, the alveolar arterial oxygen difference is phenomenal, 153 minus 66. So here, why this 153 has come? It is 715, 760 minus 45, 0.3, FiO2 is 30. So 214.5. So it is 214 minus 49 PaCO2 divided by 0.8, it is 153. So that 153 minus 56. So there is a wide alveolar oxygen difference. So there is an oxygenation failure also. So here in this is a diabetic. So diabetic, it could be DKA, respiratory distress is there. So the 7.23 says it is acidosis, and this bicarbonate 22 less than 22 is metabolic acidosis. And the last two digits of pH, as I said, it should correspond with the carbon dioxide. 7.23, last two digits, it is 23. So it is normal. So expected. So metabolic acidosis. If imagine sodium 130 and chloride 90, there is a wide anion gap. And so it is a diabetic ketoacidosis. This is the 7.39 means there is a primary metabolic acidosis. With respiratory alkalosis means the PaCO2 is 15. Bicarb is 8. So the full compensation, as I said, that 0.5, 1.5 into bicarb plus 8. So PCO2 should be 20. So it is 15. So more or less it is compensating. Now this is a little bit tough case. So you please listen carefully. See, this is pH is 7.39. PCO2 is 15. PaO2 is 90. Now my question is, don't think that if the PaO2 is 90, it means the patient is fine, because PaO2 is normal is 85 to 100. So PaO2 is fairly good, 90. But what happens, these findings are most consistent with, it is 7.39 is acidosis, bicarb is reduced, metabolic acidosis, carbon dioxide is less, probably it is respiratory alkalosis. But what happens in a surgery, it routinely happens. See, this patient is a case of SLE. You should note that, systemic lupus erythematosus. So the patient was dehydrated and the patient was given volume correction. Usually, volume correction will correct acidosis. That is the reason in diabetic ketoacidosis, we are not giving soda bicarbonate and we are giving volume. So volume corrected acidosis. So volume correction was given. He was operated, but post-operatively the patient become drowsy. SLE patient. Then is ABG with FiO2 of 30. pH is 7.38. PaCO2 is 38. Previously it was 15. Now PaCO2 is 38. PaO2 is 60. Now think why this hypoxia occurred post-operative period, whether there is microatelectasis during surgery or lungs are bad even in the preoperative period. That we have to think. Now go to the preoperative ABG, 7.39. PaCO2 15. Now it is 38. Bicarb 8. Check the oxygen status. The preoperatively what happens? The alveolo-arterial oxygen gradient you check. It is PiO2 minus PaCO2 by respiratory quotient. So PiO2 in the room here it is 150. PaCO2 is 15. 15 by 0.8 is 18. So there is a wide alveolar oxygen, arterial oxygen partial pressure difference. So it is 42. It means there is an oxygenation defect even in the preoperative period because of SLE. But by oversight, as the PaO2 is 90, the anesthetist would have taken up the case. So you have to remember that. So what I want to convey, you correlate always PaO2 with FiO2. At the same time, you also correlate with PaCO2. Then only you can find out the oxygenation failure and ventilation failure. So I think I could convince you about interpretation of arterial blood gases. I thank ISA Kerala. Thank you very much. And if you have any doubt, you can ask now, or you can send a SMS to 9361616969. I repeat, you can send the questions to 9361616969 or email dr al, dr is doctor, al is my initial, Meenakshi @gmail.com. Thank you.